All right. Morning, everybody. Welcome to this session of the THET conference. My name's Tom. I'm the honorary advisor to THET who's been roped into chair, which I'm looking forward to. So the session for today, we've been given a brief by THET to clearly articulate pioneering and alternative health system strengthening models and methodologies that meet the needs of LMIC health systems. They strive to deliver UHC to their populations. That's a fairly ambitious brief for the day, but I think hopefully we'll get some with our speakers who have got some really interesting talks lined up. There's a few housekeeping notes just before we get going, which is probably second nature now to everyone who's all got used to using Zoom for everything. Essentially, these are to stay muted during the session unless you're asked to unmute for discussions. Any slides that you see from the speakers will be attached to their Hublot profiles where available. I'll share the conversation after the two speakers have been and gone, and we'll do our best with the various hands up, message bar questions. Will and B from THET are very kindly also managing questions, and if you have been overlooked either with your hand up or your questions, it is almost certainly technical incompetence on my part as opposed to a deliberate snub, so please bear with me. So there's the hand raise function on Zoom, which you can use, or just put a question in the message bar. And then if we've missed one, then Will and B will direct me to it. And we'll see how the dialogue goes once the speakers have finished. So I think those are the housekeeping points from THET. Our two speakers today are Professor Sophie Witter from Queen Margaret University in Edinburgh, who's an economist and specialist in health systems in LMICs. And Dr. Aku Kwame, who's working for WHO at the moment, based between Geneva and Accra, and is a health systems researcher who's interested in complexity and how that penetrates into global health activity. They've both got some speeches lined up with some slides. So I'll hand over first to Sophie and then Aku to follow directly afterwards, and then we'll open up for discussion. So Sophie, when you're happy, I'll leave it over to you and I'll mute myself.
Okay, great. Thank you very much. So, can everybody see my slides?
Yeah, we can.
Great. Okay. So I've got the rather ambitious title of Health System Strengthening in Low Middle Income Countries. What and how? And so, and I've got probably too many slides, so some of them I'll pass over relatively quickly. But I'm going to start by just saying very briefly something about what we consider to be a health system. Apologies to people who are experts in the audience, but I guess we're all coming from slightly different places on this one. And then I'm going to talk a bit about what do we mean by a strong health system, which is actually surprisingly underdefined area. And then also really thinking about health system strengthening. What does it mean? What kind of interventions are we talking about? And what's the evidence base for what works, which is, again, quite a tricky area. And then I'm going to end by just picking out some lessons that came from a recent literature review on external engagement. So kind of for external engagement base, sort of cross-institutional group of researchers. I'm also going to be drawing from a review we did more recently for an evaluation of a DFID program called Making Country Health Systems Stronger. And in that we looked more at the kind of donor engagement and mechanisms for support. And then I'm also drawing a little bit from a paper I did for the Alliance on Health Policy and Systems Research, looking at learning health systems. And I hope it will all seamlessly lead into Aku's sort of more embedded reflections. So, the classic conception of a health system is the sort of WHO definition, and it's a very broad one. So it's all the activities whose primary purpose is to promote, restore, and/or maintain health. and think that's sort of fairly widely accepted definition. And the way that health system has traditionally been conceptualized for the last kind of couple of decades is focused on what we call the building blocks. So these are different components which support the overall activities, and they've been widely critiqued for being a bit blocky. And sort of viewed as somewhat discrete areas, which they're clearly not, because they're clearly all very interconnected. So this includes, for example, the health workforce, health information systems, supplies, medicines, technologies, but also health financing and governance. And everybody who works in a specific area of these thinks that theirs is the most important. And obviously that should be at the top because it affects everything. Governance people certainly think that, health financing people think that, health workforce, you know, anyway. So we all have our own little partisan areas within it, but clearly they do all have to work together. And it's also clear that some of them feed into others, and very clearly service delivery is a kind of output of a lot of those other input areas. The other aspect that's been particularly critiqued is around the engagement with the community. That's not very clear from this initial model. So lots of later sort of reorganizations have brought that element in more closely. But all of those then feed through into access, coverage, quality and safety of services. And I think there's quite a consensus around what the actual system goals are. So improved health outcomes is clearly very important, but also recognizing that it's an important social process and the responsiveness of the system matters. And there's been a very strong emphasis on kind of risk protection, including financial risk protection, and having a system that it delivers also efficiently. So recognizing that health isn't the only social goal. So I think those are relatively uncontroversial, the kind of endpoints. But as I say, the way that the system's configured and understood has been subject to a lot of debate. And I think Aku will also be talking about this as well. So the shift towards a more complex, adaptive kind of social institution approach to health systems. So that's what is a health system. So then what is a strong health system? And again, it's surprising that there's been relatively little specific thinking on this topic. So many log frames and projects and so on, you will focus on the inputs that go in. They'll often have goals that they're trying to achieve, which might be specific to some area within it, such as the health workforce, or maybe more general. But there's often been a bit of a sort of black box in the middle. So you want to get, you know, uptake of a certain service, for example. But what is the actual system meant to look like that will deliver that? And what are the kind of positive features we're really trying to get to that might sustain those services over time? And so when we did the literature review for DFID, we tried to just, in a way, almost brainstorm some of these, what we've called health system process goals. And those are, in a sense, they're not indicators because they're not developed to that level, but they are desirable features of a health system. And I'm not going to go through all of them because you can see it's quite a long list. But there are some that are really important, for example, distributed leadership. We also talk about learning cycles. So is it a system that actually feeds data back in and encourages a kind of reflection and a process of improvement based on that? You know, equally, is there a kind of systems of mutual accountability? Is it a system that pools risks well? Does it deliver integrated services? Does it work effectively with other sectors? So just to highlight some of these elements, these are kind of what we want from a system. It's important to note that they are cross-cutting, so they're not by block, although some of them do link to specific system blocks more closely, but a lot of them cut across. So what we're saying is, let's try and think in a more integrated way around the interventions we do. How do they affect these elements across the blocks and across different areas? So not being stuck in silos. And I think DFID is trying to work on some indicators sort of linked to these now. So they seem to have been quite receptive to this process. So that's just some thinking around what a strong system is or could be. But what do we mean by health system strengthening? And there has been quite a contested literature around definitions on this. And one of the reasons is there's a history to this. And the history is that there's been a lot of investment in vertical programming, so investments in specific disease areas. And there's been quite a lot of concern that those can potentially detract from the wider system. So they can potentially draw resources, attention, staff, funding into specific areas, which actually weakens the wider system around. So the whole concept of health system strengthening arose out of this debate between the vertical programming and the kind of wider system. And different agencies have different approaches. So the WHO definition on health system strengthening is very broad and doesn't really eliminate very much. It's just any array of initiatives that improves one or more functions. But others have tried to kind of narrow it down a bit more and say not everything that invests, puts, for example, inputs into a system is a system strengthening initiative. So for example, Adam and de Savigny have said that there should be not just organizational level changes, but also wider, broad, higher level system changes. And then Chi and colleagues, I think, introduced some important distinctions in a paper in 2012 where they said it needs to be beyond a disease. It needs also to be an intervention which builds relationships between building blocks and has longer term effects, and which is really tailored to a country context, so not a kind of cut and paste model that is externally, introduced. So this is some refinement of, what we classify as a health system strengthening intervention. And based on that, in the review that we did recently, we tried to kind of bring together as maybe a kind of consensus definition, which had 4 elements. So one was around the scope. So we're saying, yes, it does need to cut across building blocks in effect. It may not be designed that way, but most things, when you introduce them, they do have wider effects. You might talk about it as, for example, a human resource development program. But that human resource development program is going to affect all sorts of other areas like information systems and financing and service delivery and so on. So even if it's conceptualized as a single block type intervention, it tends to have wider effects. So is it tackling more than one block and more than one disease? We say that's one criteria relating really to scope, but also on scale, that it should have some kind of national reach and ideally more than one level of the system. So for example, also including referral levels or, higher level changes, if you like, not just at the provider level. Sustainability over time and addressing systemic blockages is obviously quite important. Nobody's interested in something short term that has, low lasting effects. And yes, there should be some effect on outcomes that we talked about. So that's the kind of health outcomes, but also equity and risk protection and responsiveness. Of course, these may not happen immediately. They may be longer term. And we think that's fine. So system changes will have effects. And sometimes it might be more important to understand to measure the short-term system effects and assume that's a kind of proxy, a stronger system, we can posit that will have outcome effects a bit later down the line. So that's kind of out there for discussion. And I think the point is there's still some debate going on around these definitional issues. So we also looked at the evidence base for kind of what works, and just to highlight some sort of health warnings at the beginning about that evidence base. So firstly, there's surprisingly few reviews that look across health system strengthening interventions. So there are a lot of reviews that might just look at one sub area, but kind of looking at it as a group is relatively few. And partly that's because there is quite a large scale of literature out there. And we think also partly because there are some boundary issues, as I said, kind of some lack of clarity around typologies and also around what actually is a health system strengthening intervention. There's also not much by way of clear evaluation framework. So typically projects are evaluated in relation to quite specific goals, but not necessarily these system strengthening ones, which may be implicit or may be unintended effects. The literature is also somewhat skewed. This is not atypical, but for example, an external project with funding is much more likely to have an evaluation than something that's kind of more organic at the local level or more locally introduced. There's also an issue of kind of labeling. So something that is seen as a new initiative is much more likely to be evaluated. And yet strengthening a kind of mainstream mechanism, like, for example, annual review processes, which are totally normal in health systems. Nobody ever looks at them because they're normal. So people will look at something that has a new label, and one of the areas I work in, which is performance-based financing, is a classic. There's been a massive amount of literature because it had this new label and it looked kind of exciting and innovative. But actually some of the mainstream practices are what we really need to be working on strengthening, and there's, but they're not exciting to funders and maybe even to ministries and so on. So there's a bias in what gets studied. Equally, more policy-oriented programs appeared to have a bigger literature. So some of the more practical areas, particularly things like supply chain strengthening, health information system, which were seen as more operational, we found far fewer studies that were published in relation to those. And also simple interventions. So interventions which don't have a lot of complex elements are easier to study. And short term. So we often study things in the short term and we miss the longer term effects. So what we're saying is that lack of robust evidence isn't an indication of lack of effect, because it may just be that nobody has been looking in the right places. So I'm not going to be able to go in the short time through all the different areas, but I do encourage you to have a look at the review if you're interested in some of the conclusions for different areas. But overall, we do highlight that there are areas of stronger evidence, and that health system strengthening is important, and that there are big opportunity costs to not doing it. We find an increasing body of evidence around governance-specific interventions, and particularly civil participation and community engagement, that these can lead to tangible health improvements, as well as improved service uptake and quality of care. And capacity development and mentoring came out as particularly important here. But also we try to bring out some of the context variables that shape and encourage these, particularly where there's acceptance of the kind of power shift that is sometimes involved in these things. So we concluded about the governance should be mainstreamed in all health system strengthening interventions, given its overall importance. And also find some good examples of kind of whole system governance approaches. So these involve much more complex, comprehensive reform plans over sustained periods of time. Having to skate a little bit through these. The health workforce, has been a lot of studies. There's been a lot of issue about quality of studies, but there's some that do, for example, link very clearly health workforce density with health outcomes. But we also identify some areas of reform that have been understudied, particularly around things sort of more macro level areas, such as HRH strategies or approaches to improving health worker information systems. For health financing, again, large evidence base, many, our typology is quite complex in terms of the types of reforms. But what we conclude is that often what's important is to go beyond the label. So it's not really what the strategy, the sort of financing strategy is called, but whether it improves the underlying fundamentals of the system, which have been quite well elaborated recently by WHO in terms of what we want to see in terms of, revenue collection and risk pooling and purchasing and so on. And then, as I said, some areas where much more study is needed, particularly around information systems and supply chain. So on the service delivery side, I'm not going to go through all of this complicated table, but just to illustrate that for each of these areas, what we've tried to do is develop a kind of typology of the key types of strengthening interventions, what evidence there is for these different dimensions, and some commentary around the kind of findings and contextual factors that favor them. But broadly speaking, for service delivery, there's now a reasonable evidence base looking at these multi-component interventions, and particularly ones which reinforce one another, saying that there's evidence for comprehensive service integration, particularly where it looks across a continuum of care delivery. But where the intervention is designed more predominantly to increase uptake of a specific service, such as HIV, and there isn't a broader investment in wider health systems, that the impact comes out much less strongly from the evidence. So equally, there's a lot of studies now on package interventions like the integrated management of childhood illness, and those often have an effect on increased uptake, but health outcomes data was more mixed. And overall, the role of community engagement in the design and implementation comes out as an important factor in higher effectiveness. So overall, what are the factors that are likely to increase success? I mean, I've talked a bit about some of those, and some of them look a bit motherhood and apple pie, but we do know that they're obviously hard to achieve in many cases. So clearly, political commitment to a process is helpful in achieving success, but also shared societal values. So where there's some broader consensus behind the reforms, taking advantage of windows of opportunity. Sort of reform moments can often be crises, for example, that can introduce, where change can be introduced. Sustained commitment. So none of these are short-term measures, and clearly if something comes in as a very short-term program, that's going to be challenging in terms of achieving some kind of coherent change. This issue of iterative learning, which has come very much out of this learning health system literature, community engagement, which I've already mentioned, and the importance of the individual and organizational capacity building and mentoring. So what we're saying is it's not necessarily the design or what the reform is called, but more the implementation process and its quality, and the extent to which these are well adapted to the context. And this brings us, and I'm sure that Aku will come on to this more, this importance of the sort of system software. So the relationships and the kind of values that are embodied. And those also tend to link to the history. So people are very much influenced by their past experiences, and where you've had, for example, multiple unsuccessful reforms or not sustained reforms introduced, that tends to condition people's reaction to the next set of kind of donor projects or interventions. So just to finish up, just to pick out a few items from the literature review that we did for DFID that was more focused on kind of donor interventions and what we can learn from the literature. I thought it was interesting just to show the kind of mechanisms that we picked up in this literature review from different donor programs. We did a sort of inductive coding of what types of intervention donors were supporting in these programs. You can see there are 23 here, and some of them are much more frequently used than others. So new systems and training comes up the top of the list. But also some others, such as development and conducting analyses, whereas issues such as relationships between organisations obviously less commonly included, at least in the studies that met the review criteria. Most donor programs have a range of mechanisms. They don't just one. So the range was kind of 1 to 14 of these mechanisms in any given program, and the average was 6. They are common mechanisms were more. We also tried to just map them against the different, what we call the health system process goals. And you can see that some, like, investments in infrastructure are much more common. And it's also interesting to note the areas that are less prioritized apparently within the programming. So for example, this issue about promoting a more preventive approach didn't come out of any of the studies that we included. So I think it's good to think about some of these. Have we got the balance of mechanisms right that we're supporting, but also the kind of focus within the system strengthening, because some of those nodes are really crucial and maybe are not easy for externals to engage in. So things like organizational culture change and risk pooling perhaps are more controversial or more political, or, we can think about why that might be. There's probably a reason for those patterns that we are finding. And so final slide, just to say that clearly some factors that are favorable or more challenging emerged, which I think probably I've already really covered, but this issue of ownership and buy-in is very important as a general success factor, and clearly alignment with national plans. And this is not a given for donor investments that they are aligned, some more than others. Consistent in-country program staff is a real challenge and comes up time and time again, that where you have very quick changing donor staff in country, you lose the kind of connection and the continuity and the coherence of the engagement. And clearly at the national level, there are also some important factors which can be problematic, again, often around attrition, loss of skilled staff, and too much, political instability, just to pick out some examples. So I think I've kind of gone over quite a lot there, relatively superficially, but I'm hoping we'll come back to some of those discussions after the next presentation. So thank you very much.
Thanks so much, Sophie. That was amazing, and perfectly to time as well.
Oh, good. So, I was worried I was running over, but since my watch doesn't work, I've lost track.
No, that was perfect. Before we move on to Aku, does anybody have a very quick question of clarity or fact before we move on? We'll save any other bigger questions till after both presentations. But if there's anything, I'm just scanning down the list and just seeing if anyone's got their hand up, but I can't see any. And on the chat, fine. Okay, Aku, we'll hand over to you for the second, unless I've missed a question, hopefully not.
Great. So good morning, good afternoon, good evening, everyone. Pleasure to be here. I'm delighted to be with you, and thanks, Tom, and thank you, Sophie, for setting such an expert scene. I just want to start by thanking the organizers for the opportunity to be here and to really discuss some very interesting issues. So I would like to pick up on some of the things that Sophie has raised in her talk, and also just draw a little bit on some of the points that were raised in the plenary session this morning, and hope that we can have a very interesting discussion about how the partnership model can perhaps evolve or mature given the changing global context and the changing global shifts. So of course, we all know that we're aware of the changing global challenges. COVID-19 has posed a challenge to health systems. Right now, we're in conversations of now health systems having to respond to the protracted COVID pandemic and what that looks like in terms of increasing preparedness. We're speaking again about the issues of resilience. Meanwhile, health systems are also having to balance access to essential and routine services, and we're seeing also an increase as governments are having to choose between health protections versus health promotions. And very interestingly within that, when we're speaking about health systems strengthening, there's also a bit of a shifting discussion, more appreciation of the fact that the health systems, as we've traditionally considered them, the 6 building blocks, there's an expansion around the concept of a health system. We know that health systems are social systems that are embedded within other systems, but they're also connected to other systems like road systems, food systems. And so what do all of those connections between systems mean for strengthening systems for health? And of course, just the very logistics of travel limitations and what that means to supporting partnerships and supporting relationship building. This is what we're all having to face. So clearly these all have an implication for the partnership model and how the partnership model can attend to supporting the achievement of the SDGs in this coming decade. And so we were given some provocations this morning to think about, and I just want to raise some questions to frame some of what I want to raise today with you. Thinking about how partnership can be much more systems-based and thinking for capacity strengthening. So I just want to pause here to just pick up on the terminology. We have the challenge when we're speaking about systems, health systems approaches. Often there's a conflation. Do we mean the health system building blocks? Are we speaking about an intervention that touches, as Sophie said, on all 6 building blocks? Or are we speaking more in terms of system science and actually being able to understand the behavior of a system and look for patterns of emergence, self-organization, non-linearity? So here, when I'm speaking about systems-based approaches, what I'm referring to is I'm referring to interventions that are explicitly looking at change within the interdependencies of the actors and the organizations they find themselves in. So that's how I'll be referring to systems-based approaches. And then also when we're speaking about capacity strengthening, what does that look like from an organizational perspective beyond training? So a few questions to provoke us when we're thinking about partnership. What does partnership look like in the face of these increasing uncertainties? When we're speaking about the purpose of partnership, particularly as it relates to the issues of quality, what kinds of purposes should we be setting for partnership? Can partnership become more effective? And of course, our measures of effectiveness will relate to the purpose that we identify. And can partnerships become more systemic? So I just want to dip into theory just for a moment. I won't be here very long. But when we're speaking about continuous quality improvements, one of the things that comes up in relation to the systemic view is appreciating the inherent dualities of continuous quality improvement. So the fact that as a process, quality improvements look not only at strengthening organizational control, so issues of standardization, issues of uniformity, but that's paradoxical to the other underlying goal of CQI, which is really also about supporting organizational creativity, looking at organizational learning. And so how does that duality get balanced? How do those tensions between the two get balanced when we're looking at interventions that support quality improvement? And when we take that in the organizational perspective, what we're also aware of is that the organizational cultures and the organizational structures that exist, and Sophie spoke about the histories and norms and values that exist within organizations, whether the organization is a team, whether it's a network, or whether it's a facility. The practice of quality improvement will be driven by those underlying factors. And so whether the goal tends to organizational control versus whether it tends to organizational learning will be driven by those implicit underlying factors. And the third point is that when organizational uncertainties are high, then the quality improvement goal also tends towards organizational learning. So it's important for us to lay this as a foundation for us to think then about the purposes behind quality improvement in this context of increasing uncertainties and multiple uncertainties that health systems are facing. I wanted to share briefly an example from some work that we've done in Ghana, which wasn't looking specifically at clinically based teams. Here we were looking at supporting district managers in their routine management and leadership, using quality improvement methods, but really trying to understand, could we institutionalize systems thinking? And what I just want you to take away from the causal loop diagram on the right is, if you look at the right hand of the image, it's basically relating to the introduction of this intervention that we had, looking at the results in the short term versus what happened in the medium term. And we saw that over the short term, there was great uptake of system practices, new practices being observed within the organization, increased outputs in terms of the identified results that the managers wanted to achieve. And so that was very encouraging. After time, we saw, of course, that those practices stopped for a variety of reasons, but mainly to do with the context, the organizational context and the broader context. And so those systems thinking practices that had at first been taken up became dissipated. And what we learned from that experience is that oftentimes when we're introducing complex interventions, the complex intervention itself often has less power than the complexity of the context. And also, Sophie made mention that over time, the intervention has interactions with the context. And so what we see as outcomes or as results in the short term is not always what we see over the medium, over the long term, as the intervention gets modulated by the context over time. And organizational reflection is something that's very important, but it's something that's very resource intensive as well, not only in time, but also in finances. And so when we begin to think about how can we institutionalize systems approaches, how can we ensure that the organization is able to hold on to these newly formed practices, it raises some questions for us. And so what I want to propose is thinking about how can the partnership model think about this context of uncertainty, and then being a way to promote and support organizational adaptability. And so organizational adaptability is the concept of letting the organization being able to respond and be adaptive and create spaces for adaptive thinking and adaptive practices to be developed. So it involves positioning the organization to be able to face adaptive challenges. It focuses on looking at the organization and the people within the organization to be able to unleash the potentials that are stored up within. It uses systems level approaches. So sometimes it involves systems thinking tools like causal loop diagrams or social network analyses, process maps, systems, dynamic modelings, etc. But also looking at the system, the relationships between people, using reflective practice in order to be able to nudge or change or create new structures and procedures and processes, and having a learning orientation within the organization. And importantly, it's really about the collectivity of the capacity strengthening approaches, where the focus becomes at the institutional level. And so really moving from the individual to the institutional, and thinking about what capacities does the institution require in order to support learning. So I want to just introduce here a framework to just think about how we can consider the organization, and to say that within every organization there are always two tensions that are existent. Of course, an organization has usually as its primary function its operational function. So here we're speaking about the delivery of quality services, and an organization will work and introduce practices to ensure the maximum efficiencies of creating and being able to deliver quality services. It's about producing results, it's about performance, and it's about using the existing knowledge, skills, and practice at play and trying to improve those. Now, what organizational adaptability says is that there's a secondary function, which is the exploratory function within an organization. And those two are always in existence, but perhaps in different balance to one another. And how can other competencies and skills that are related to creative thinking, that are related to thinking about new knowledge, new skills and practices, being entrepreneurial in practice and in focus, and what organizational adaptability seeks to do is to create adaptive spaces where the operational function and the exploratory function can come together. And it's cyclic also, as Sophie mentioned. So in the adaptive space is where the negotiation and the networking and the thinking together arises. So new ideas are emergent. They're part of that systemic behavior. They're emergent. But as they get worked through the organization, they get laid into new procedures, new routines. And so it's this, and we can imagine that if this is the organization, it's also subject to external forces. So pressures, contexts that are changing, that are challenging. And so those pressures are pressing into how this organization is able to balance these two functions. And so this is a question for us to discuss today, is what then is needed to support this kind of shift towards more institutional capacity strengthening in order to support and create adaptive spaces within organizations. So really, it's about fostering skills required to navigate these two functions. And strengthening really the internal network. So building relationships with people, building the relational dynamics, supporting organizational learning explicitly. We speak a lot about organizational learning. We speak about learning organizations, and we expect people to be able to function in them. And yet one of the things that we're not really doing very well is actually capacitating people with the skills around negotiation, around advocacy, around brokering, around facilitation. And these are really the skills that we need to step across boundaries, step across disciplines, step across different kinds of trainings in order to allow for that collaborative leadership across the organization, that distributed leadership, and making sure that those processes get documented and fed into and integrated into new ways of working within the organization. So let me just share an example with work that we're currently engaged in 3 countries. We're working in Botswana, Timor-Leste, and Pakistan, working with district teams where they are experimenting and applying systems thinking tools to routine practice. So it's a systems-based approach in the sense that the project is active at national level. So the national governments are linked to these districts. They've identified them. They're accompanying and working with them quite closely. We're also working very closely with local research institutions as a first step to get them familiar and using the systems thinking tools. And so there's that whole menu that I referred to earlier about the kinds of tools that can be used. But what's critical is that the research institutions are accompanying these district teams to really understand what are their prime challenges right now, what are the issues that they want to try to apply the systems thinking tools to. And we've also, from the beginning, built in this space for reflective practice. And the reflective practice is very important because, again, when we come to speak about systems thinking, we are often talking about the new mental models that have to be developed. And yet we don't really know how that happens. And so we're going through this process of documentation and reflection for the district teams to be able to explore, what is happening to them individually and personally when they engage with these systems thinking tools, but what are they also seeing in terms of outcomes within the performance of their health systems. And of course, the project has been challenged by COVID because the district teams have been very, very busy responding to COVID. So we've been working mainly with the research institutions at this point. And what's been quite encouraging is that the research teams themselves are now very strongly capacitated to be able to do that facilitation around the reflective practice. But what's been interesting to see is that 2 things I would point out. The first was sort of the initial discomfort because there wasn't really a blueprint model to follow. Everyone was expecting, okay, well, just give us the tools and tell us how to use them and what to apply them to, and we can move on. But taking the time to first really understand what the challenges are and what would be the most useful in terms of the questions that need to be asked in order for then the appropriate tool to be deployed has taken time. And then, of course, the time that it takes to go through reflection, the time that it takes to build relationships. And even in this virtual context that we're now working with, the teams have been very delighted to be able to sit on Zoom calls and have these webinars going through the use of systems thinking tools. It doesn't take the place of that face-to-face tactile engagement with one another, but we do live in a day where technology is able to support us. So those are very, very preliminary findings, but I think that we usually underestimate the amount of time that it takes to really set new mental models. And when we want to start thinking about sustaining systems thinking, not only in thought, but also in practice, we have to be aware of what this takes. So just to close and to maybe open up a broader discussion, when thinking then about the partnership model and how it can incorporate more systems level approaches to capacity strengthening, one thought might be then to be explicit in the shift from individual to institutional capacity strengthening and what that looks like context of organizations, the purpose of organizational learning. The second point would be around thinking of the skills and the competencies required in order to navigate and support and develop adaptive spaces, to be able to consider that exploratory function that an organization has, and consider that in intention or in balance with its operational function. And then finally, just being able to think more broadly and more long-term about how to institutionalize emergent ideas and get them integrated into the operational processes of structures. So let me end there, and really looking forward to a very rich discussion. Thanks very much.
Thanks so much, Aku. That was brilliant. Before we open up for discussion again, does anyone have any specific questions of fact or clarity around Aku's talk that they want to raise just at the minute before we move on? I'm going to quickly scan down as I peer at my screen trying to see any hands raised. No, I don't see any. So to get things moving, the question in a way that I'd like to put to the two of you to see what your thoughts on are is that from the two presentations you've given us, for the health partnership model that's evolved over time, essentially there seems to be two challenges for those people engaged in health partnerships. One is the intellectual challenge dwelt on more by you, Aku, in terms of both understanding systems thinking and those approaches for themselves, so as introduce them into a health partnership, and to really have a sense of how to do that. And that feeds into the second point, which is the operational challenge, which, Sophie, I think you've touched on really well, which is, you know, these are big elements of a system, which for a institutional partnership often grounded in a clinical relationship and a particular set of personalities can feel very high and far off and hard to achieve. On a personal level, I think that probably keys into the health partnership model, which is in a period of evolution from a quite kind of kitchen table, grassroots undertaking, and which has evolved over time into a much bigger entity, but still with partnerships that are on that spectrum from small, local, clinically focused to quite big institutional established entities. And so I guess my question for both of you is, if you were to start at the kitchen table end of a health partnership, how does a health partnership that starts off as a clinical relationship between two people go through a process whereby it's then ready to address the big picture health system building blocks that you've dwelt on, Sophie, through a systems thinking lens that, Aki, you've explored really well? And so, Sophie, if I start with you, do you have any sense of how a simple partnership starts to evolve to tackle some of those big issues that you've talked about?
Oh yeah, I thought I was muted, but I'm not. Yeah, I mean, these are very difficult questions, obviously. Luckily, I've just drunk some coffee. So, no, I mean, I think, so one issue which Aku was just raising is around those changing mental models. And I guess part of it, just at a very low level, a local level, personal level, is around supporting that process whereby those individuals become, thought changes in their organization and are able to feed that through. So, because I think these things matter at all levels. So whichever your kind of scale or level of engagement, there's always scope to support the kind of reflective practice that Aku was just discussing. These are not short-term changes, and I think we would all agree on that. It would be very hard to do that effectively in a kind of in-out situation. Where you build longer-term relationships and there's some continuity, very powerful. I mean, it's encouraging that thinking at a slightly different scale, though, because most people, even clinicians, have the power to start asking questions around the systems in their institutions, around how it fits with other services, around how it's going to be sustained, how do we get this broadened? So it's just moving away from that kind of project mentality. Most people have a project, because it's that's what they're paid to do, or not paid to do if they're volunteers, but that's what they're engaged to do. But also because it's just a more practical. How do I know if this is working? So it's also thinking about the kind of learning loop. How do, even if it doesn't have to be a sort of RCT kind of level of evidence, but what are we measuring? How can we tell? Where can we get feedback? How can we encourage our bosses to even care about whether it's, sometimes it's even on that level. So, there's some people are brilliant at doing this naturally, others have to learn it. How can I improve? What if I change this? Sometimes we're really constrained by our organizational culture that doesn't encourage it. And there's indeed often risks to being an entrepreneur, aren't there? There are, if I just sit here doing nothing much inefficiently, nobody's going to notice me. If I start to change things and it goes wrong, I'm going to be sanctioned. Unfortunately, the incentives in institutions are often hostile to more thoughtful, innovative approaches, and that's a big issue, because we're asking people then to take personal risks, and that's there's some sort of ethics around that, really. They can get into trouble if they're in an environment that doesn't really function, to support that kind of work. So those can be, I think, the incentives and the institutional environment, if we're just working with like a team or an individual, that can be a very challenging area. But I think those conversations and encouraging, because sometimes people can so they need to sort of, you're doing this year, but how will you manage that next year? Or, are other teams going to join you? Or how could you spread the message about what you're doing to make, because it is going back to that very ambitious health system strengthening, definitely let's increase the scope, let's whatever, increase the connections, etc. It was quite demanding, but I think that all relationships have the power to change the way people think and work. Even, and frankly, I think any positive change is valuable. We can't always achieve it at a massive scale, but as long as we have that kind of goal in mind, and we are helping people to think about things in a slightly broader way. Maybe it's just a simple process change. Maybe my hospital could start to have, an annual meeting where we sit together and share our lessons that we didn't do earlier, or, across the departmental silos, or anything that breaks down those barriers is kind of a move in the right direction, because ultimately we are working towards collective goals in theory, but we need to operationalize that in practice. We don't always work that way. We're often, in silos, or even in competition, or just, minor personal animosity. So yeah, it's, I think there's a lot that the partnership model can take forward from some of the points that have come out so far. But I recognise it's not always without some risks. So I do think people need to also be open-minded, about what's realistic, and to judge themselves kindly according to what's an appropriate goal in that context and setting. Some cultures are very punitive. There's a lot of external factors we have to take into account. Others are more open to change and so on. So we have to work within our possibilities, but don't be discouraged by setting sort of ridiculously unambitious goals. And I think it's good to have quite honest conversations with people around, well, if you did that, what would happen? And do you think that would work? And would there be implications? And how can you win over, how could you win others over to kind of support that? And so there's a lot of quite soft skills around leadership and advocacy that many, medical staff in particular, obviously that's not what they're trained to do, but some people have developed it or naturally have it. So we have a lot of leaders. They just need a bit of support. So I'm optimistic, but maybe wrongly so. I don't know. Aku, what do you think?
Thanks, Sophie. No, I mean, I share your optimism, and I think that you said a lot of key points, which I would agree with. The one being about thinking about time and about scope. So even at a small scale level, at the kitchen table with 2 or 3 people, you can certainly think a bit more long term about what it is that you want to do. So you're not seeing your work as being just within the next 6 or 12 months, but you're really thinking generationally in terms of, how does this small piece, what will we do to sustain this small seed, for a next generation of leaders or workers? That's one. And then being wider in scope, so thinking who else can be brought in, and very much, beginning to think in terms of feedback, which, as you say, many of us are not trained to think in this way, but I think the fundamentals of it are being more broad, looking more widely, and see what else do I have to consider in this plan of action, or this route that I'm taking. And I also would agree with you that the issues around incentives are very, very difficult, organizational incentives, and there are risks at times. But part of the organizational intelligence or awareness is knowing where there are pockets, where there are leverage points, where there are people who can be co-opted, to support our cause, or people who either need to be influenced or who can do the influencing for us. So it's challenging, but it's not impossible. And I think that just sort of reorienting the goal in that way, be much wider and longer term in our thinking, is a very simple way to start. And if a partnership between 2 people or 3 people, it starts from there, then you can make it much more sophisticated and build upon it after that. But I think those are the basics.
Mm.
Fantastic, thank you both. I'm just quickly scanning down all the questions that have started to pop up on the sidebar. And so I'm just trying to see which ones I can synthesize quickly. So here's the first question from Dota, I think, is about some examples of institutional health partnerships that have contributed to health system strengthening. And so I wonder, maybe the best people to talk about that is anyone from THETConf. Are there any particular health partnership examples that you can think of that have particularly ticked the box of health system strengthening that you would use as an exemplar that the rest of the partnerships could learn from? So looking at, there's Will and Charlotte and B. Does anybody from THET want to talk at all about particularly successful partnerships that you think fit that brief? Apologies for putting you on the spot.
Yeah, so we've got another session on another breakout tomorrow, exploring exactly that question. So I'd recommend either attending that or watching the record if you're not able to tomorrow, because we've got a couple of really good examples of partnerships that have been able to do that. One of which is the Kings and Somaliland partnership that's been going now, I think, for a couple of decades. I can send a quick link in the chat box to have a little look. I think it's best if you can hear it from the horse's mouth, so to speak, tomorrow.
Brilliant, thanks, Will. Scanning through some of the other ones, and I can see now why this gets so tricky, because conversations start, it's very hard to keep track of them all. So I think there's an interesting one here from Jessica to say, ask what your thoughts are on how health partnerships can think about the broader picture of health system strengthening, whilst also working to ensure that quality of work remains high and continues to improve. And that touches on a question that I think came from Will from THET, which is the extent to which focusing on straitjacket a partnership or a project towards looking at something very particular. And I think there's probably a trade-off somewhere, isn't there, between your breadth of focus on trying to do everything broadly and sustainably across all these different domains, and a relentless focus on quality of the thing that you see as your core business, maybe your core condition, or the key element of your partnership that's got you there in the first place. And so thinking about it in terms of the health systems literature and in terms of systems thinking, how do you go about that sort of risk trade-off between trying to look broadly and think broadly, but also looking really carefully at the quality of the few particular deliverables that you're trying to achieve.
Yeah, I mean, in a general sense, trade-offs are never easily made in a generic way. They're always made in a context and in a specific set of constraints. And I think this links a little bit with Aku's put a nice diagram around the different, the connection between the sort of what the organization has to deliver and its kind of entrepreneurial functions. And I see it a little bit similar. They have to be both. They do sometimes come into tension with one another, but yeah, both are important, and the balance between them, I guess, shifts a little bit over time, depending on the urgency of the context as well. So I think, well, I don't know, but I mean, I'm just off the top of my head, because I'm not sure of any actual sort of evidence on this. In one way of balancing that may just be to have different people who lead on different aspects so they don't get neglected. I think the tendency is normally to focus on the kind of core deliverables. And this is what we're here to do. This is what we have to focus on. This service needs to be improved in X way, or these people need to be trained, or whatever the kind of core functions are that the partnership is meant to be working on, tend to dominate. I think it's unusual that they would be neglected in relation to broader system things. So my sense is there's often lacking the kind of champion who's a little bit provocative, who says, yeah, but what's this achieving more broadly? How does this connect with other things? How is it going to be sustained, etc.? So it's useful almost maybe to a point within any partnership, somebody whose job it is to ask difficult questions, and provoke people to think a bit outside their box. I've not ever come across a situation where that wider thinking was so distracting that people didn't deliver the core. It's normally the risk is the other way, in my experience. I don't know what Aku thinks, but so yeah, because I think the system thinking is a harder mindset somehow. It's a bit more lateral, it's creative, it's connective. So yeah. So my sense is that's the function we need to try and build in a bit more, because ultimately we don't want to walk away and what we've done is actually just crumbles. It's not, it hasn't achieved any kind of fundamental change, even in a team mentality or whatever. It's also a measurement issue, isn't it? We're talking about some intangible things that are harder to measure and therefore don't get valued and don't get done. It's much easier to measure the hard, the kind of concrete elements. So that's where this boring academic stuff about frameworks and things comes in, because we're trying to capture it so that we can recognize its importance, saying we need to have a way of measuring it, we need to have a way of presenting it to donors, if you like, saying, look, this is what we've done, even if it's just a set of qualitative case studies or whatever. It's evidence that something on this bigger scale or connected areas has changed. And so I do think the kind of that monitoring feedback stuff is important, because we have to but the things that are most important are often just the hardest to measure, and that's just the way the world is. So, but we can find ways of dealing with that. But it is a challenge. So I think I've just pulled around various other questions there, but never mind.
I mean, to add to that, I think again it also comes back to this this awareness of what the boundary of the system is, and being aware that whatever it is that you're doing, whatever change that you've introduced in your core business, as time goes on, that those changes are going to begin to interact with the context. So there has to be some kind of capacity for feedback within the organization, so that it can respond to the environment as the environment is responding to the changes that you are bringing forth. And I think many at times, once we start on a particular project or a particular effort, we don't modulate it over time, and that's where we get into trouble, because then we get all of these consequences that we haven't been wide enough in our thinking to capture, and that's when things begin to happen that maybe we're not able to understand or we haven't accounted for. So the ability to think more broadly, and we like to think that systems thinking is this really technical and abstract thing. It can be, but it's also just simply looking for the effects and considering them, considering them in terms of feedback, considering them in terms of time, and just having that ability within ourselves or within our team, or making space for it within the work that's happening. So I think that's one way of, yes, absolutely keeping focus and being true to the core effort, but then also